Okay, here we go. This is the cardiovascular section of the CPT manual 2017. First part starts with your table of contents. You have everything heart and pericardium related. This includes valve issues, that kind of stuff. Then you have the next section within cardiovascular is your arteries and veins section. Within it comes all kinds of stuff, different congenital anomalies, your dialysis fistulas being put in, that kind of thing. So when you think of this section, organize it in your mind to two different sections within this section. One is heart and everything related to the heart, and then one is your arteries and veins, your vascular system. Great pictures in here. This would be a great place to write notes, put in terms, that kind of thing that you may need. You do have a little bit of the hemolytic and lymph system. There's just a few codes, maybe on 4 or 5 pages. This is where you would find your lymphadenectomies, that type of thing. And then you have just maybe 6 or 8 codes for the mediastinum and the diaphragm. But the bulk of the cardiovascular system is your cardio, your heart, and anything pertaining to the heart, vessels, valves, and then all of your vein and artery issues. Okay, so cardiovascular system starts with the heart and pericardium, specifically the pericardium. Make sure you read all of your parentheses. This particular parentheses is telling you that the scope, that with this VATS procedure, you would also need to code the scope. So you would need to use your thoracoscopic scope codes in addition to that. Pericardiocentesis, this is really, this area, almost more than the other areas previously, is where your medical terminology really kind of starts kicking in. Really think about your suffixes, your otomies, ectomies, centesis, desis. All of those different suffixes really give you the action that's being done. All right, so then we go into pacemaker and implantable defibrillators. Here starts some good guidelines, kind of explains to you what the pacemaker system is, what the different lingo and what's involved in it, the different parts of it. What a single chamber pacemaker system is, a dual chamber. I underline these, not necessarily for me, but I think for you guys learning to get your mind around specifically what you're dealing with really is very, very helpful. Then you have a whole page here of a lot of guidelines, a lot of technical stuff. Don't know that you need to sit and absolutely memorize it at this point. You might want to get familiar with the codes first and then maybe come back to it once we hit advanced. Just really kind of technical in here. It does help you kind of understand in greater detail what they're talking about with pulse generators, with electrodes. You really do need to know the difference between a pacemaker and a cardioverter defibrillator in this section. They added this page, this is on page 197, a couple of years back. They've added several tables in here. I'm not as used to this table, so I have to go in every year. I go in and really kind of underline just for me so that if I wanted to use it, I could at a glance figure it out. Normally, and we'll come back to this in just a minute, normally what I do is I bracket. You see how I have pacemakers starting here? So from 33202 all the way to 33214 are pacemakers. So I know if I'm looking for a pacemaker, anything, whether it's an insertion, a replacement, changing a lead, changing a battery, whatever, if it pertains to a pacemaker, it's in this section. And then I go on, and I'm going back to that page, don't worry. And then starting with 33240, see my arrows all the way 233270. I gotta read this one over here. I guess 7.1, actually, I guess maybe all the way to 7.3. These are kind of strange defibrillator codes, but they do pertain to defibrillators. So from 33240 through the rest of this section would be a defibrillator. But let's go back to this one page just to kind of get our minds around stuff. So different lingo, pacemaker or defibrillator. If you're dealing, once you figure out which one you're dealing with, is it a single electrode or single lead, or is it a dual lead? Is it a single chamber, dual chamber? Is it a temporary? Is it a permanent? All of those kinds of questions have to be asked. So in order to kind of narrow down what you're looking for, there are 4 pieces of information you really need to figure out. Number 1, is whatever is being implanted temporary or permanent? 2, is it a single lead or a dual lead? 3, is it atrial, ventricular, or both? And 4, what was the approach? Is it sub-Q through the skin, or are they actually doing a thoracotomy, which goes through the chest, through the ribs? Not as common doing it that way. Usually your sub-Q is the most common. Now, obviously, the first question that isn't even listed here is it a pacemaker or defibrillator? Anytime you see lingo, pulse generator, that's the battery. You might see battery and your code description says pulse generator, or vice versa. They're the same thing. A little bit I have underlined here because you will encounter this on one of the scenarios, this last paragraph, about whether or not you use fluoroscopy or not. So in this particular instance, you would, and that's what it's telling you. So if you see that underlined, that's why it's there. Okay, so let's kind of divide up this table like I've divided up all the different codes. So your first 1, 2, 3, 4 codes all have to do with electrodes. The lead, electrodes, wires, whatever, lingo, that's what these all have to do with. So I have these bracketed off. You may see them as leads. You can see them as electrode. The next 1, 2, 3 have to do with battery only. Initial pulse generator, pulse generator, pulse generator. So I just have these as lead only and battery only. So if I'm looking for any of those only kind of codes, I might do pretty good looking here and not having to fiddle with a lot of new other codes. Your next is this is an initial placement of a single lead, new placement of a dual, new placement of a multi. So there's multiple leads, more than 2. And I just kind of single those out. So if I'm looking for that, then my eyes see it. If I'm not looking for it, I ignore it. This next is a defibrillator only. It's not a pacemaker. Then we get into some of our removals. We have one converter from a single to a dual. Then we have our removals. So 1, 2, 3, 4 are removals of the pulse generators. And then we have the remaining removal of electrodes. Remember, electrodes are leads, wires, however it's documented. Here pertains to pacemakers. Here pertains to implantable defibrillators or cardioverter defibrillators, however you want to say it. So that's just kind of how you make this page a little bit more manageable. Your guidelines up here in the corner do a great job. I've starred them, do a great job of explaining what your single, dual, or multi-leads are. Then I go in and I have my pacemaker section here. Good pictures. I would sit and maybe study some of the pictures, might give you a little bit better idea. Most pacemakers are placed under the left clavicle in that little fat pocket My mom's is actually on the right side. She's very strange. She likes to do everything completely different. Doesn't mean to, but she ends up doing it. Okay, so then these codes here in the middle, if you look at them, they're repair codes. They're funky, permanent insertion of electrodes only kind of codes. They're not putting in the whole system or of either pacemaker or defibrillators. They're just kind of different. They're relocating stuff. They're repositioning stuff. They're repairing stuff. That's what kind of this middle part is. Same thing over here. Still here, removal, just funky stuff in here. And then starts with your 33240. This is your defibrillator section. Very, very similar, both the pacemaker and the defibrillator section, very, very similar on the codes that you'll pick or find to pick from. Lingo's very, very similar. I do have a note up here written because it's a code that sometimes I have trouble finding years ago, so I would put it here and I just keep bringing it over from manual to manual every year. If during a pacemaker or defibrillator insertion or replacing leads or whatever during the procedure, if they do threshold testing, and that's how they would, a minute. I am so sorry about that. Threshold testing. Then I just put here at the time of insertion, if they've done threshold testing, it would be 93641. 93641. That keeps me from having to go hunting for it. And it's right here available to me, and I won't forget it if I write it in like that. Okay. Next we go into our electrophysiologic operative procedures. These are different ablation surgeries. Sorry if you keep seeing I'm not set up too good today. Different ablation surgeries. Typically what they're talking about is the electrical activity within the heart, maybe with the SA node. They have to go in if a patient has chronic arrhythmias like atrial fib, something like that. They go into the SA node or the AV node and they ablate, they destroy that area where the electrical impulses are coming from, and then sometimes that will help control whatever the arrhythmia is. On a lot of atrial fib folks, they do that, and then they're dependent on a pacemaker and they're still in atrial fib. So, you know, sometimes it works, sometimes it doesn't. Ablated means destroyed. And then they specifically talk about different arrhythmias, whether they're from like a Wolff Parkinson, or I guess it's Wolff Parkinson White. It used to only be Wolff Parkinson. Different atria, originating type of arrhythmias, and you can just kind of read down and then be able to find which code would be the most applicable to whatever your scenario is. But that's what this section is. Also very, very common that you may need to pick up another code along with it if they have some type of guidance or that kind of thing. Oh, another common is a MAZE. Your MAZE procedures or your modified MAZE, M-A-Z-E. Then we have two patient activated event recorder. A lot of times the docs call this a loop, L-O-O-P recorder. So I just kind of have that written just so it triggers something in me that I know where to go. Then we get into the heart valves, the great vessels and the heart valves. You can see we have the aortic valve. And there isn't too awful much for me to talk about with these things for right now. I just want you to get familiar with if you had a scenario dealing with the tricuspid valve, then you would kind of know where to go. And at least it narrows down the playing field. So that was our aortic. Now we have our mitral valve, pulmonary valve, and then we have our tricuspid, where Did I skip a page? Oh, here's our sorry, I skipped our tricuspid. So our it's mitral, tricuspid, and then our pulmonary. Sorry about that. This is when you need to go in and underline. Like I told you guys, obviously mine is not, would be very good to highlight or underline, and then you wouldn't do what I just did. Okay, so far in this section, we've done around the heart, pericardium, around the heart stuff. We've done pacemakers and defibrillators. Okay. A little bit of ablation stuff. So that's for heart rhythms, electrical activity in the heart. And then we go into the valves of the heart. We know we have 4. And I gave you a not very nice way to memorize the 4 valves, but it at least gets you there. And then now we're going to go into the actual vessels on the heart. Vessels on the heart. A few little anomalies. These are just abnormalities. So here is your bypass grafts on the heart. Not bypass grafts in the leg, but this is cardiac on the heart bypass grafts. So if your family member is going in and they have 3 vessels in the heart that are blocked and they're going to get, quote, bypassed, this is where you would find the codes. So couple of things we need to know in here. Just kind of looking over the section. You have your venous grafts. You have combined grafts. And then you have artery grafts. Artery grafts here. Okay, so there's 3 sections. Venous grafts, combined grafts, and artery grafts. This is all cabbage. So let's talk about them. If you have a bypass graft and the grafts are provided by veins only, that means the arteries in the heart have clogged up and they are bypassing around just like they're making a detour around a part of the highway that's being worked on. They're going to bypass around like what these pictures have. They're bypassing around the blockage. And those bypasses were all done by veins, vein only, then this is where you would go. Vein only. If, I'm going to turn the page, if you have blockages in the heart and all of the bypasses were done by arteries only, no veins were used, only arteries, the artery only is where you would go. Okay, so we have bypasses done only by vein, and we have bypasses done only by artery. Now, most everybody has combined. Think back about a family member or someone that you know had a bypass. They had the long incision on their chest, and then they have the long incisions down their legs. Not so long anymore. They've done, and I'll show you that code in a minute. That is generally when they cut through the sternum to open up the chest. They harvest the mammary artery. Males or females, the mammary artery. And they try to use that because they've already cut through it. It's not going to be any good anymore. They try to harvest from there. So most people have at least one artery bypass, and then they have some saphenous vein taken out of their legs. So they normally have a combined artery and vein bypass. If that is the case, which is the most common, for the artery bypass, you use here. For the combined artery and venous graft, you do your add-on codes for the veins. So if it's combined artery and vein, you pick up however many arteries first. Then, and you see these are all standalone, artery first. Then you pick up your vein, add-on code veins. So now let's talk, okay, one more thing. We talked about taking the veins out of the legs. They would have the long incisions on their legs. Nowadays, they use a scope. to get the best, make the smallest incisions and get the best part of the veins. And they use a scope for that. This code up here, 33508, is the endoscopic code for harvesting the saphenous vein in the leg. So if you have documentation that a scope was used to harvest that vein, this is the code that you would use. So now we kind of have a basis of the codes. Let's talk about the notes in here. Starting with this 33508, if the scope is used, star that because you're gonna add that on. Codes 33510 to 33516. These are vein only. If every bypass being done by the physician is of veins and no arteries, this is the only place you will go for a CABG. Let's turn the page. Code 33533 to 33548. Actually, it only goes to 33536. Sorry about that. But all of these are artery. But your actual codes that you would use with a CABG is 33533 to 33536. If your bypass is only artery, there's no veins used in the bypasses, this is where you would get your codes. If you have the combined, then we have to go backwards. So here is where you put a note. Code artery first and then combined vein. This is if you have both artery and vein bypasses. You code here first for however many artery bypasses you have, probably only one or two, maybe only one. Then the remaining that are vein bypasses, you use in this combined. So it's code 33517, 18, and 19. These are the combined. I put a note here, combined code artery first. That means I have to pick up my artery first, then I do my add-on vein. I have notes up here because you have to label your bypasses if it's the right coronary, left circumflex, left anterior descending, whatever it is. You can get, all of these from, trying to get there, at the front of your book, your manual, all of these are listed on your cheat, okay? But I put them here so that my eyes remember to do it because I'm sometimes not good at remembering modifiers of any kind. So I do that and then I know I have to do it. Okay, so this is CABGs, coronary artery bypass graft. This is for coronary arteries that are blocked, vein only, combined vein and artery, artery only. We know our harvesting code, 33508, if a scope was used. So that's your CABG codes. Then we get into a lot more technical, probably not seen very much unless you work for a cardiologist. There's a whole lot of this section that's really involved. These are different cardiac anomalies that you could find. Septal defects, the septum divides the left and the right heart. Congenital stuff, tetralogy of Fallot, just different kind of anomalies. Getting into venous anomalies, shunting, different shunting issues, transposition of great vessels. This is stuff, a lot of this you were probably born with and either are figuring out late in life, you've compensated well, or you're young and you're figuring it out. Truncus arteriosus is just a malformation. There's only one artery. Different aortic anomalies. So again, if you are reading your scenario and you've identified that it's an aortic anomaly or a cardiac anomaly, you know within a few pages of where to go for that. Your thoracic aortic aneurysms, these would not be the abdominal. Those probably, depending on where they are on the aorta, maybe in a different place, those AAAs. But these are thoracic. Different endovascular repair of the thoracic aorta. Again, remember the big, great vessels, the big vessels in and out of the heart. That's still what we're talking about. Pulmonary artery issues. This is the artery going into the lungs, away from the heart. And then you have a few codes for your heart-lung transplant. I have never used any of these codes because I just haven't ever worked at a place or facility or anything that use these codes. Okay, so now we're getting into some ECMO, some oxygenation and life support type of codes. These are very, very technical, very, very, very technical. You would see ECMO or ECLS very much in here. This table, don't get too bogged down with this here, I promise. We have a lot of changed codes, and they're kind of still working this area. So every year we see a little bit of a change to it. Don't get too bogged down in it, please, please. Okay, then we get into cardiac assist. Let's say patient needs a coronary artery bypass graft, and their heart is just really tired, and they don't think that the patient right now would survive the surgery. So they may need to use some kind of cardiac assist in order to take some of the workload off the heart for a day or two, let it rest, in order to kind of build the patient up for surgery. That's kind of what you may see in here. All different forms of it, but that's kind of what you will see in this area. So this is a cardiac assist area. Now we're out of the heart and we're into arteries and veins. So quit thinking about the heart. Now we're just thinking about arteries and veins. Entire body, arteries and veins, but not the heart. So we have embolectomies and thrombectomies. These are clots. Different places. These are arterial, these are venous, but these are clots. Here's your AAA, abdominal aortic aneurysm. Your AAA, we had the thoracic already. Our AAA is in a different place. I'm just kind of looking at some of these. I'm not going over every single, we're just kind of getting familiar here. And there are several pages in here that we just don't get huge into. Still working on repair of the aorta, different places within the aorta. Could be more abdominal, could be more into the pelvic area. We have direct repair of aneurysms. And then we have, this is direct, means they open it completely. They are directly looking at it. They're not using a scope and looking at it through a camera. A direct repair would be looking right at it. And if you look, some of these are, you really have to read carefully. Like this is a ruptured aneurysm in the carotid, and they're going in through a neck. This is 35002. 35081, aneurysm, aortic, abdominal aorta. So you really have to read these. These could be a direct repair, potentially anywhere. Popliteal is behind the knee. Superficial femoral. You see they're just different locations. May help you to locate where these are with some of your pictures in the front of the cardiovascular. It has the vein, the vein's the blue and the artery's the red picture. So that would very much help you in this area to look at. Here we have repair of vessels other than a fistula. Remember, a fistula is a tube, like a new road built between two places it shouldn't be. That's usually not a good thing if you have a fistula. Then we have our thromboendarterectomies. Thromboendarterectomies, all different kinds of arteries anywhere in the body. Very, very common in the carotids. to have a thromboendarterectomy or a carotid endarterectomy to clean out the plaque. Okay, then we have bypass grafts. I have here not coronary. These are bypass grafts, not done on the heart. They can be done anywhere else in the body, but not cardiac, not on the heart. So put not coronary. And if you look here, you have your harvesting, which we're already used to that now. And then you have your bypass grafts, and then it just kind of, you just find your body part, find your different vessels. This was vein, bypass graft veins. This is in situ vein, so that in situ means place of origin. Other than vein, so these are synthetic, other than vein bypasses that they're putting in. Composite grafts. And again, just kind of, once you read what your scenario is, then think where you need to be. First question is this cardiac or something else besides cardiac, vessel or vascular? Once you pick that out, then you'll know whether to go to the front of this section or the back of the section. Different arterial transposition codes. They're transposing. Excision and repair codes on vessels. Vascular procedures, this is injecting stuff in maybe for a picture, like a venography here. 36005 is an extremity venography, so this is the injection procedure for that graphy picture that they're going to take. I have notes here. This is more for me than anything. These had to do with the renal vein and the adrenal vein, and I had to place in my mind where these were, and they're above the kidneys, so I put renal. That was only for me. I doubt that that's anything that you guys would necessarily need to know. I was used to, if you see this writing here, I was used to the dialysis codes being in here, and they've changed. So I just had to make myself a note of where they had changed. There again, you probably don't need that note because you didn't know it before. So that's okay. Again, we're still in some, I was going to show you in this vascular injections procedure. You will see, like with code 36011, first order, second order. These are all selective catheters. A selective catheter means the physician can place the catheter, pull it out, place it someplace else. Pull it out, place it someplace else. That's a selective catheter. A non-selective catheter is like a flashlight. When you put it in, all you can see is just what the light illuminates. So that's the difference between the two. Your first order and second order is when you'll have to use your appendix L. Remember, for the vascular families, this is the area that I was talking about that you'll need that all through here. You've got second order, third order, and beyond. So non-selective and selective catheters, so you have to know those differences, and then you have to know your vascular families, but you use your appendix L for that. Moving into angiographies of the carotids. Again, this is not cardiac. This is angiographies of anything other than the heart. So you have arteries, you have veins, and again, you may want to highlight some of these titles. If the patient needed a transfusion, 36430, this is where you get it. Transfusion of blood. Doesn't matter the units. You don't do a timesing or anything. That's your transfusion of blood. Central venous access procedures. And again, we're coming up on another table that you may or may not like. There are four in this section. There are 4 pieces of information that you've got to pull out in order to choose the right central venous access. Now, as we talk about this, do not get central venous access confused with central insertion. Okay, so in here, there are 4 things, and I've written them here. You need to know, is the catheter they're placing tunneled or non-tunneled? And they have pictures of them. This is a tunneled. They may tap in to the right subclavian up here, and then it's tunneled underneath the skin, the fat, and then comes out here on your chest. A non-tunneled, like this, taps right in and it's right where it is. So these are good pictures of a tunneled and a non-tunneled. So all of these, let's go back, all of these are achieving central venous access. So they're all tapping into veins, all to get central venous access. So 1, is it tunneled or non-tunneled? 2, was it centrally inserted or peripherally inserted? This is where you can't get confused. Centrally inserted is on the trunk of the body. So for central venous access, they will centrally insert the catheter on the trunk. If it's peripherally inserted, then it's in the arms and legs, peripheral, arms and legs. Okay, then you need to know the age of the patient and was there a port or pump. Those are the easy ones. Once you get over that central or peripheral inserted, you're good. So this information that I have listed here, you will kind of read through here and you'll be able to see how those 4 pieces of information are vital to picking the right code. Also, if any of these codes, I just have a note because I think I ran across this and I made myself a note so I didn't have to think about it again. If you use any of these codes for chemotherapy infusion, then you code also the infusion. Here is the table that sums up everything that I just said. Is it tunneled, non-tunneled, tunneled, centrally tunneled, tunneled, with port, with pump, peripheral, age, okay? So this sums up everything I just went over. Again, I learned the codes through actual codes. I didn't learn them by the tables. I do think for you guys just learning the tables, this table at least is very good. You may want to put lots of notes in. This is for insertion, this is repair, there's a removal. You know, it just kind of sums up 4 or 5 pages and puts it into one, which is very, very good. So these are continued codes, all having to do with your central venous access. Now we're into our hemodialysis access. Hemodialysis is for dialysis patients, renal failure patients. There's 2 kinds. You can have peritoneal, which is done through the abdomen, or you can have hemodialysis, which is done through the vascular system. Typically what they do, and this is what this picture is showing you, the blue is a vein, the red is an artery. If a patient is going to have to be on dialysis, probably long term, or at least in however long a life they do have, they go in, usually in the forearm here. Sorry about that cord. Usually in the forearm, and they transpose or they put together the artery and the vein so that when they're pulling out the blood, there's a faster way, and then when they're putting the clean blood back in, it gets into the body faster. So this is what we call an AV, arteriovenous, AV fistula. It's man-made, artificially made, but it's what generally long-term hemodialysis patients will have. And you may hear the docs talk about it. They can feel a thrill. If you touch it, you can feel a little bit of a thrill or a vibrating. And that's how you know that they have a fistula. All of this section is going to have to do with those kinds of issues in patients. So if you aren't dealing with dialysis, you would not be in this section. They have added several pages here. Lots, again, fairly technical. They do have some great definitions that will help you kind of get in your mind what the dialysis type of lingo is, and specifically what they're doing with certain procedures. So it was very good to add this for clarification. It's just a little technical. So these are still dialysis. This particular one, I had to write a note here because the graft or the AV fistula is already present. This is work on it. So I had to make myself a note to remind myself that the graft is already there. That's not putting in something new. Moving into transcatheter procedures, a little bit breakdown here: mechanical thrombectomies, arterial mechanical thrombectomies, thrombolytic infusions, clot buster kind of infusions if someone's having a stroke, that kind of thing. Then it's just kind of divided up. Different filters that have been put in the vena cava if a patient is real susceptible to clots or plaque. Those filters can be put in. Very, very common. Also in the groin, in the femoral artery, they put different filters in, dumping into the aorta or dumping out of the aorta into the legs. Different endovascular or revascularization. So maybe a blood clot is found behind a knee. So they're going to go in and they're going to take out the clot and revascularize the lower part of the leg. That's the kind of stuff they're talking about in here. They can do the balloon angioplasties, just like we're kind of used to them in the heart. They can do them in any other part of the body too. They can do the balloon procedures. That's what's in through here, angioplasty. They put a balloon, use a catheter, put a balloon in whatever the vascular vessel is, and then they kind of blow up the balloon and it pushes the plaque onto the sides of the vessel and gives a bigger opening for the blood to flow through. Usually is not lasting. Usually clogs right back up. Ligation, this section, it's tying off. If you ligate something, you tie it off. So that's what these. And then we get into the hemolytic and lymphatic. Remember, there's just very few. It's only like, I don't know, 3 or 4 pages total back here. Spleen, it's a very vascular hemolytic hemopoietic vessel or organ. Sorry, I'll get my words right in a minute. So if there's any action, if they're taking the spleen out, if they're repairing it, whatever it is, this is where you would find those codes. General, this is your bone marrow. Again, bone marrow is vascular. It's part of the circulatory system. So this is where any of your bone marrow harvesting, those kinds of codes come from. Into the lymph system, lymphatic system. If a patient's having maybe they have prostate cancer and they're having their prostate removed, and they have to remove some lymph nodes from around the pelvic area, you would come here and pick up a code as well, because this is where your lymphadenectomies are. I do have a note here, code 38505 to 38525. You would, for any of these codes, you code also 38792 for the blue sentinel node. If they used the dye and made the sentinel node blue, use that injection, then you would also code 38792. And then mediastinum, this is in your diaphragm. Very few codes here, obviously very, very specific. Code 38792 is the one we just made the note about over here. But if you read that actual code, and I put beside here used with breast, etc., this is the tracer or the identification of the sentinel node. So it kind of links them. All right. I want to look at one thing real fast. Okay, so I'm not going to do the medicine section. You do have in the cardiovascular section, you do have some of your angioplasty, your stent placement, your arteriogram. They are all in the medicine section. They're found in the medicine section, but I think I'm going to cover them when we actually do the medicine section. It'll be a little out of order, but I don't think it'll be as much moving around. But just make note, maybe you need to make note or something, that for cardiac, arteriograms, angioplasty, stents, those procedures are actually in the medicine section. And then for any echoes, those are actually found in radiological. So you can find your cardiac and vascular stuff in 2 or 3 different places in the CPT. So for right now, although your book may talk about some of these other areas, for right now, let's just focus on this area, and then I'll pick up and highlight those procedures in the other sections when we get there.